Thank you, Nadia.
You're welcome.
Good evening, everybody. This is Engin Oral from Istanbul. And this is our webinar series. This is the fourth one. We just did 3 You can look at these webinars in our websites. And today we have special guest, young and special guest, Dr. Sebastian Schäfer from Münster, Germany. He is actually a gynecologic oncologist and he is the head of the Endometriosis Center of the Münster. And he is also advisory board member in our European Endometriosis League. He has a lot of duty on the German societies like the endometriosis and the minimal invasive surgery. He was at the same time Young West board member and Young West ambassador in World Endometriosis Society. He has training at the Münster. Now he's at the Münster. His main interest in minimal invasive surgery and endometriosis. Today, we will discuss how is ultrasonography linked to surgery in advanced endometriosis. Please, Dr. Schäfer.
Well, thank you, Engin, for this nice introduction. And let me say thank you for the chance and the opportunity of doing this presentation here. I think the webinar series that the EEL has started and that which was your idea mainly is a really nice addition to, well, it's it's something that can be done in this time of COVID very nicely in order to get together still. So I'm going to talk about the ultrasonography and as you said, the question, how is it linked to surgery in advanced endometriosis? And let me start, hold on, there we are. Let me start with the first slide. This is basically already like a summary slide, and I did this on purpose that I put this at the very beginning because I think it is important to make clear that ultrasonography is a key tool, the key diagnostic tool basically in endometriosis diagnostic workup. And to my opinion, it should be mandatory in preoperative planning. It should be mandatory also in every exam that you do because of endometriosis in patients. And I'm aware of the fact that in different countries, the setup is differently. In Germany, most of the time, the surgeon, him or herself, will already be trained in ultrasonography. And especially if you're doing surgery in endometriosis, I think you should be experienced in performing the ultrasound yourself. For me, the ultrasound basically is like the extension of my hands, if you will, during the exam. It's just part of the everyday exam. It allows me to basically see a lot. And with the advances of ultrasound nowadays, I think that the time is over in which we thought that endometriosis can only be really described performing surgery. The details are delivered basically by ultrasonography. So what this does for surgery is it improves surgical planning and it therefore guarantees reduction of unnecessary repetitive interventions and I think should be relevant for everybody. So the routine technique that I'm using here in Münster and to my awareness is used in most centers, at least here in Germany, is the 2D transvaginal ultrasound. I think it's important to have a specific setup in which you will look into certain planes, but you should also guide your sonography using tenderness guiding. That means that if you're doing an exam and you find out that there's a tender point, let's say on the sacro-uterine ligament, you will use the ultrasound, especially there, in order to see if there is a lesion that can be found or not. Possible additions I put on the slide here are transabdominal ultrasound in cases of kidney assessment that needs to be done in cases of bigger uteri which exceed the pelvis. Then there is a place for transrectal ultrasonography. Also, you can use the transvaginal probe for that. You could also use the rectoscope. and the transrectal sound probe for performing this. You might also add rectal water contrast, or you might add saline or gel in order to enhance your assessment of especially the vagina. Obviously, there's a place for 3D ultrasound. I think in certain cases the 3D helps. In most cases it is not absolutely necessary, but obviously it's a nice tool to have. And I think that elastography can be used in certain areas of endometriosis diagnosis as well. To my opinion, for example, also in adenomyosis diagnosis. So I think it's important to state that the ultrasound does not stand by itself. It's part of the diagnostic routine workup, which consists of medical history. Obviously, you will have to talk about symptoms with a patient, about pain symptoms, obviously, and also about infertility. The vaginal inspection needs to be added, and then after that, a bimanual palpation, to my opinion, always including rectovaginal exam at least once in the workup with a patient. If you suspect endometriosis, it should be a rectovaginal palpation at least once in this workup. And then you add the ultrasound, and after that you have sufficient diagnosis most of the times for most patients. In some cases, they need further exams, and I will go into that just in some detail later on. At the end, I put the diagnostic and therapeutic laparoscopy. I think the time is over in which the laparoscopy was basically used in order to see clearly, because we thought that we were not able to see enough beforehand. So the laparoscopy should be prepared perfectly by the exam that I'm describing, and it should then not only be diagnostic but already therapeutic in its strategy, basically. Obviously, you can also use the robot if you have it, or you could also perform open surgery. But because of the advances in laparoscopy and also the advantages of laparoscopy, most of the surgeries will be performed minimally invasive. The exam, I already talked about that a little bit, should always be rectovaginal. I highlighted the areas which you have to address directly during the exam in order to see if there are lesions there, how big those lesions are, if they're symptomatic or not. This is something that is important for your strategy for the treatment later on, because if something is asymptomatic, possibly you do not have to take this out. And the palpation also helps you in orienting your ultrasound afterwards. You will obviously look at everything during the ultrasound, but you will specifically look in areas in which there have been signs of tenderness. If you're looking into the publications from the IDEA group, there is a setup of the ultrasound scan or ultrasound exam that they suggest. They basically say that it's a good idea to start with like a general exam and then go into specifics. Obviously, that's absolutely possible. I'm just describing here the way that I'm doing it when I'm seeing my patients. And keep in mind that when I'm seeing patients, they're already coming to an endometriosis center. So it's clear that it's because of most of it, or a lot of times, deep infiltrating endometriosis. It is because of endometriosis. So I'm basically doing the specialized exam from the very beginning. I think it's very important to start at the orifice of the vagina. When I started out as a young resident, my impression was that the gynecologist can see in his or her ultrasound the uterus, the ovaries, and that's it. And obviously, you all know that that's not the case. So you should be aware of everything that you're looking at. And I think it's important to understand the ultrasound just the same way the radiologist understands his or her MRI or CT scan. You should just look at the body of the patient as you go during the scan systematically. Everything that you're looking at, and if you have findings there, you should visualize that, quantify it, and document it in two perpendicular planes. Maybe add certain tools like elastography and Doppler. And then the way I'm doing it is I'm starting at the orifice, and then I'm firstly looking at the anterior compartment consisting of the urethra, the bladder, the vesicouterine septum, and the ureter. I can also use the sliding sign in this area in order to see if there are adhesions which are possibly significant or indicative of endometriosis. I'm looking at the posterior compartment consisting of the vagina, the rectovaginal septum, the rectum itself, obviously using the sliding sign here. I'm going to go into that a little later. And after that, that's when I'm starting with the uterus and the perimetria, the sacrouterine ligaments and the ovaries. In cases of deep infiltrating endometriosis, in cases of ovarian endometriosis, and in cases of symptoms in the kidney area, I will also look at the kidneys using the transabdominal scan, and maybe basically symptom guided, I will look at the groin, the umbilicus, and scars. Now, I brought you just a little snip of this exam, not to really go into very much detail, but just to show you this is where I start looking. So the first thing I'm going to do is I'm going to look at the urethra, then I'm going to look at basically the bladder, and then go on from there, basically. I took this picture from the IDEA Group publication from 2016, and looking at the anterior compartment, it's not only necessary to scan everything, but to then describe correctly where the finding really is. And looking at the bladder especially, it's important not only to see that there is a lesion, but also to see what is the relationship of the lesion to the trigone area, what is the relationship to the ureter, how far away is it from the ureter, are they involved or not, because this is very important for the planning of the possible operation that is going to follow. This is an example of such a bladder endometriosis in a patient, which in this case was in the bladder dome. This might look like this in the OR, and you can see that the sensitivity is all right, but the specificity is really good. So this is an exam which will really help you, and to assess the bladder is, I would say, something that is rather easy. The challenge is more to basically see where the ureters are and how the relationship and the closeness of the lesion to the ureters basically is. Speaking of the ureters, this is the next thing that I'm going to look at. And in the picture here, in this little video snip, on the lower part of the picture, you can see the ureter here in the area which is belonging to the bladder wall, and you can follow the ureter. I will show that in more pictures later on, at least until the uterine vessels. And you can see, if you're looking at the ureter here, you can already see that a little bit, the peristalsis of the ureter. You can see the function of the ureter, and you can see if there's stenosis or dilation or something like that. In this little video, you can, I think, see nicely how the ureter does his peristalsis, and you can see the urine going into the bladder. So diagnosis of the ureter can be done using the ultrasound. You do not necessarily have to use something like a CT scan or something like an MRI or so. Now, it's important to follow the ureter then, and one of the landmarks that you have to look to are the uterine vessels. I find it myself, I would not say easy, but very reproducible to see the ureter until the uterine vessels. Above that, up to the level of the common celiac vessels, it's more challenging, and I will say that it's, at least for me, not always possible to follow the ureter there, but at least until this point, it is most of the time possible to see the ureters. Looking at the picture on the right side, which I took from a publication from Gynotodelist, this shows you what is basically the thing that you're looking for. You can see with the double plus signs here, the deep infiltrating endometriosis in between the stenotic ureter and the dilation up above that. In this case, possibly you will also have dilation of the kidneys, but not always. So it's important also to look at the ureter and then to assess the kidneys itself additionally. The next organ or group of organs is basically the posterior compartment. And in this area, you will look at the rectum, at the septum, the rectovaginal septum at the vagina, and then the relationship with the uterus and to the sides. And after that, you will look at the sacrouterine ligaments and the perimetrium. It's very much possible to see lesions in the rectovaginal space. I think even if the sensitivity is in this meta-analysis only 49%, I think if there is a lesion in the rectovaginal septum, you will find it rather easily, I think, because you can put your probe right next to it, and that's a very that's a big advantage also over the MRI, from my opinion, basically. Obviously, it's rare to only have rectovaginal endometriosis without vaginal or rectal involvement, but it occurs. It might look like this. You will always look for hypoechogenic lesions, like in this picture or over here. And this will be something, especially in addition with symptoms, which is very suspicious of endometriosis. Most of the time, you will not only have, as I said, the rectovaginal septum involved, but at least the vagina or possibly the rectum, or both, basically. And so you can see if you do the ultrasound at this stage, this is exactly the information that you need in order to really plan the operation well. Because one of the things, at least in my department, that will be very challenging is the fact, when do you plan to have a surgeon with you? When do you do the operative planning in a way that you have a surgeon that can come to the OR once you have to do the resection of the bowel, for example? So this is what this ultrasound really needs to deliver and needs to do. And from my opinion, most of the time, the assessment is very good using the ultrasound, as I already said. Then in the vagina, sometimes it's nice to already to also put in some gel or saline into the vagina in order to increase the contrast. But from my opinion, it's not always necessary. Most of the time, you will find the lesion. Sometimes you will find the lesion even during the inspection, basically during the vaginal inspection. So the challenge is not so much to see that there is vaginal endometriosis, but the challenge is to not only see the tip of the iceberg in the vagina, but to see the endometriosis to assess how much it goes into the depth, basically. I think if you're looking at the vaginal inspection here, it's important to state that you need separate specula. And if you have a video or at least a colposcopy that you can use, you can zoom in. So the diagnosis is really clear, but this is only the tip of the iceberg. That's where this basically comes in, delivers you the information concerning how much the width of the lesion really is. Now, the next thing in this posterior compartment will be bowel endometriosis, and in contrast to what I showed you for the vagina, for the bladder, ureters, and so on, the sensitivity in diagnosing endometriosis with the ultrasound is really good, with 91%. This is a meta-analysis from 2016. It's also the IDEA group which has published this. And you can see this hypoechogenic lesion in the rectal frontal wall, which is the deep infiltrating endometriosis. Well, this is a large lesion. A lesion like that will be found rather easily, I think. In those cases in which it is not so easy, the sliding sign comes in. Sliding sign means that you basically push onto the uterus, and you can do that also with a hand. There is sliding between the posterior uterine wall and the vagina and the rectum. You do not have suspicion of adhesions. If there is no sliding, there's suspicion of adhesions, and in patients with suspicion of endometriosis, obviously suspicion of endometriosis of the rectovaginal or space or the bowel itself. So this is how it is performed. From my experience, it's also a lot of times possible to just push with a probe, and you do not necessarily always need the second hand, but obviously you can perform this sliding sign as it is shown here as well. This is what a positive sliding sign looks like. So you can very nicely see that the uterus and the rectal and other bowel behind, they slide against each other. There's no suspicion of adhesions here. So looking at the bowel, what is it that you're looking for? What are the information that you need, that you want to have from the ultrasound? First of all, you will have to assess which segment is involved when you're looking at endometriosis of the bowel. And with the transvaginal ultrasound, you will be able to assess the lower rectum, which is close to the rectovaginal septum and underneath the pouch of Douglas, which will not be visible during laparoscopy unless you know that there is something underneath and you're looking specifically for it. You will be able to look at the anterior or the upper rectum. You will look at the junction to the sigmoid and obviously the sigmoid itself. And above that, basically the ultrasound from the vagina is limited. So if you have suspicion of something else above that, you will need another diagnostic tool for that. The second question that needs to be answered is, what size does this lesion really have? So you're just measuring it, but you're not only measuring it in one dimension, but also always in two perpendicular planes. And if you're looking at these pictures, you can see the sagittal plane here and the transverse plane here. And the other question that can be answered already here is how much of the circumference of the bowel is involved. In this case, I would say 50% is involved. So you have a longer lesion with 50% involvement. This basically tells you, from my experience at least, that probably you will have to perform, if you want to remove this, perform a rectal segmental resection. The next question that needs to be answered is, what is the length of the segment? So not only the portion of the circumference is important, but also the length of the involvement of the bowel, and possibly also the presence of skip lesions in order to decide what type of surgery you will perform on the bowel and what you need to prepare, basically. And the last information that you need is, what is the distance between the lesion to the anal sphincter. So if you have all of these informations, looking at lesions, you will be able to assess not only that there is a lesion, but also what this means if you want to take it out. So you can already say or talk with the patient about the possible operations, and you will be able to say, well, probably you will need segmental resection, or probably it will be, or it might be possible to just do disc resection or just do shaving. Obviously, the strategy of operation is different in different departments in different countries, so I'm not going to go into when to do what. I think that is something for another lecture, but I'm just saying that the ultrasound helps you with this differentiation a lot. Sometimes you need some additional information, I will say that, and that is when pelvic MRI can be necessary or can be good to also perform that. Our surgeons, they really like also the rectal endosonography, and they will perform this. You will basically see the same lesion, but just in another dimension. I will say that the rectal endosonography, we add it to our ultrasound because the surgeon, him or herself, who will join us in the OR, he or she will perform this rectal endosonography, and just as I'm doing my ultrasound, he or she will be able to get a better feel for the patient and for the lesion. So I think it's important that they do that. But the shortcomings of this type of ultrasound, I would say, is that you can only have a two-dimensional view of the lesion, which you will have in the other. In the transvaginal ultrasound, you will be able to shift the plane, which you cannot do in this rectal endosonography. Now, the next topic that I'm going to talk to you about a little bit is the topic of the uterus. In this picture already, you can see that the posterior wall is a little thicker than the anterior wall. This might be indicative of adenomyosis. Other possible signs are focal myometrial lesions, just as in this picture. Then the myometrial asymmetry, which I've highlighted here a little bit in these two planes that I'm showing you. We will look at the junctional zone, thickening of the junctional zone, but to my opinion, especially also irregularity of the junctional zone and disruptions of the junctional zone are signs of endometriosis, so of adenomyosis. So this is how it might look like in the OR, and obviously you're thinking about adenomyosis when looking at that. I summarized the signs, the ultrasonographic signs of adenomyosis in this slide, which have been published so far in addition to the asymmetry, which I've shown you, the focal lesion and the junctional zone, the myometrial islands and subendometrial microcysts. The myometrium might be hyper and hypoechoic, so inhomogeneous. There might be a globular, bigger uterus, if you will. There could just be general hypertrophy, and also elasticity using the elastographic exam might be inhomogeneous, or it might be different in certain areas, which are then suspicious of adenomyosis if you're looking at focal adenomyosis. The Musa group published this nice work here in 2015, which summarizes the main findings that I've already talked to you about. So I'm just pointing this out again, also for you to know where to look, at which publication to look if you want to do some further reading afterwards. Now, I brought to you this little video of a uterine adenomyosis, uterine elastography, and on the left side you see the B mode. On the right side you see the I think what this shows really nicely is that in this case of diffuse adenomyosis, you have the inhomogeneous presentation basically of the myometrium using the elastography. So it might be an additional tool. I'm at present looking into this in a prospective study, also comparing that to MRI, but the study has not been closed yet so far, so the publication is still waiting. If you're looking at the uterus, the 2D ultrasound is sufficient in most cases, I think, but 3D can be helpful, especially if you want to do offline analysis later on, or if you want to show those pictures to an expert. Obviously, you can also show videos and pictures of a 2D ultrasound to an expert, but the 3D is really nice for that. And if you're looking at the junctional zone, sometimes 3D is nicer, or a nice addition to assess the junctional zone. Now, after having looked at the uterus completely, what I'm doing normally is that I'm moving the ultrasound probe to the left and to the right in order to look at the perimetria, look at the uterosacral ligaments, and sometimes you will find lesions like this in the picture here, which is basically a deep infiltrating endometriosis of the sacrouterine ligament. Again, specificity is better than sensitivity, but it can be demonstrated nicely in the ultrasound. The next organ that I'm looking at, the next thing that I'm looking at is are the ovaries, and you might find some ultrasound findings like this, the ground glass phenomenon, which is rather typical of endometriosis. But it's not always so easy. Sometimes endometrioma, this was an endometrioma, afterwards in surgery and in histology looks a little more atypical. This looked more like a cystadenoma, but it still was an endometrioma. It's important to differentiate normal findings like the corpus luteum, I think. The ring of fire, which is demonstrated on the left, is helpful for that, especially in my opinion. You will have to differentiate dermoid cysts like this, which are hyperechogenic. Obviously, follicular cyst, this is not so much of a challenge. Cystadenoma and even ovarian cancer might be differential diagnoses, and you can make the differentiation nicely using the ultrasound. obviously, because I'm ending here with the ovarian cancer, there are shortcomings in diagnosis of early diagnosis of ovarian cancer with the ultrasound. I'm not saying that this is a screening tool, but I'm saying that when you're looking at the ovary, be aware of the changes there, and also think of things like this even in younger patients, because sometimes, especially the endometriosis patients, they might have changes here already early on in their life. So, but in most cases, it will be more typical, like this, for example. On the right, you see some pictures from the OR. So you're looking at endometrioma. Now, I hope I could show you during this lecture so far that the ultrasound is really able to completely describe the endometriosis that the patients presents with, basically. So one could ask oneself, do we still need the MRI? And I would say that we do not need the MRI most of the time, but in some cases, yes. So I think there are exceptions. Certain cases are better assessed using the MRI. One example is the thoracic endometriosis, as you can see here. This you obviously will not find with the transvaginal ultrasound, and the ultrasound of the thorax, because of the gas in the lungs, is there are shortcomings, so the MRI is good for this. Another topic which is nicely evaluated by the MRI is the sciatic endometriosis. I think in cases in which you suspect that, MRIs should be performed. So what are indications for the MRI? In summary, I think if you have a suspicion of multifocal deep infiltrating endometriosis, MRI is a good idea, because sometimes you will see maybe most of the lesions, but if you remember the bowel pictures that I showed you, there might be a rectal endometriosis, and there might be something further up which you will not see in the ultrasound because you cannot reach outside of the pelvis. So this might be a good case for an MRI. Another case might be the adenomyosis. My personal opinion is that if you do not really need it because you want to do, let's say, planning of an OSADA procedure, for example, I think it's expendable. You do not absolutely need an adenomyosis MRI in order to make this diagnosis. And the third indication of an MRI, I think, is extrapelvic or suspicion of extrapelvic endometriosis, especially deep infiltrating endometriosis. So I think I'm quicker than I thought, but I think this is good for the discussion. So in conclusion, I will come to, I hope I could show you that the 2D ultrasound is the first-line diagnostic tool and should be used in every exam because of endometriosis. The rectovaginal palpation can be used for orientation of the ultrasound. The key word here is tenderness-guided ultrasonography. You should not see the ultrasound as standing alone. It should be accompanied by medical history, emphasizing especially pain symptoms and sterility. It should be accompanied by vaginal inspection, so using separate specula, especially looking at the posterior fornix. The ultrasound is able, I think I could show you that, to nicely diagnose ovarian endometriosis, adenomyosis, and deep infiltrating endometriosis. If you have deep infiltrating or ovarian endometriosis, you should also perform renal ultrasonography, because even if you do not find something directly on the ureter in the transvaginal ultrasound, sometimes there is something further up which you cannot see. So a renal ultrasound is important. And additional exams, to my opinion, are optional. They're reserved for special cases, and they should be used possibly in preoperative planning, but not in every case. Thanks for your attention.
Thank you, Dr. Schäfer. Thank you so much. You are on time and a lot of good slides about ultrasonography. Thank you so much.
You're welcome. I hope this fulfilled the expectations.
Yes, it was good for me, and I believe it was good for the audience. Actually, we have the Caterina extracaustus in our one of the Yes, Katerina is here. Katerina, can you hear me? Could you do?
You can hear me?
Okay, yes, thank you. Thank you,
Yes.
Katerina.
Thank you, Sebastian, for the lectures. And just to understand, you said that you ask for magnetic resonance only if you suspect that the endometriosis is a little bit outside the pelvis. Sometimes it happens that you are sure that there is some endometriosis because the symptoms are very typical, but you don't see nothing by ultrasound.
Right.
Is this not a case to go to magnetic resonance?
Yeah, obviously, yes. You're absolutely right. I think that if you, I'm not trying to make the case against the MRI. I'm just trying to make the case very much for the ultrasound. I think the ultrasound should be the first line diagnostic tool, and I think it's in the hands of experienced people, be it specialist ultrasonographers or surgeons which also perform the ultrasound. It's a good tool which allows us to understand the individual case and the individual patient very well, and you will be able nowadays to really see what the OR will show you then again as well. So most of the time I think that if the lesions are in the area which can be seen during the ultrasound is enough. But obviously there are some cases in which you describe the case just like that, in which the ultrasound does not help you that much, or if you really suspect that there is something because the patient is in a lot of pain, I would rather do then the MRI than just do a blind, if you will, laparoscopy, obviously.
Yes, because we are sure that laparoscopy often cannot help you because ultrasound can see more in the deep department than laparoscopy, and this is why we are really pushing for the non-invasive diagnosis of endometriosis, which leads also to a non-invasive treatment without surgery. And I think this is the new view that we have now, that to go also to treatment without surgery because we can see better under the peritoneum. The only problem remains the superficial endometriosis, which I think that you agree with me that we cannot do it by ultrasound. And this is why sometimes we can ask for laparoscopy, despite we can go also to treatment directly without looking for that.
Yeah, I think you're absolutely right. I think that let me say this. When I started out, this is like 14 years ago. So not so much for some people, but I think rather some time already. My impression was that in a lot of cases, there was ultrasound which was performed, but it was not as good as it is nowadays. So a lot of cases, well, we would tell our patients, well, you have symptoms of endometriosis. We do not know what you have. We don't see anything. Let's just do an operation. I think this is something that should not be done anymore. And I think the advances of ultrasound really help us with that, basically. I think the ultrasound is really able to, obviously in the hands of people that are dedicated to that, really able to describe well what type of endometriosis the individual patient has. And obviously there will be patients which need surgery after that, but it's always better to go into with a clear picture than into it blindly. So you can comfort the patient better. You can your planning is better. You possibly need to have a surgeon for a visceral surgeon, for example, who you will not have organized to be with you if you just doing a blind operation. So this is, I think, also one of the key and main points of the ultrasound. On the one hand, being able to avoid unnecessary surgery, absolutely agree. I do agree with that, absolutely. But on the other hand, also to perfectly prepare the surgery that is necessary.
We have some questions from audience. Thank you for the conversation. Actually, Dr. Schäfer, they are asking, and Dr. Kale and Dr. Donovan from the audience, they are asking, do you use sonography during the surgery or just before the surgery?
Most of the time, just before the surgery, actually.
At the OR, right? At the OR.
No, well, the way it works in Münster at the moment is, if I plan to perform a surgery, I myself see the patient. I do the exam and I do the ultrasound in relative temporal proximity, if you will, to the operation. That means that I'm not doing the ultrasound and then like 3 months later I'm doing the surgery. It should be close to the surgery. Most of the time it will not be on the same day, but it's in close enough proximity to the surgery that I can be sure. I think I can be sure that I will not have additional findings in between. Ultrasound in the OR, from time to time we do that if we do not find the lesions that we found on the ultrasound before during the operation. But what we can do during the operation as well is that we have access to our computer system in the OR. We have access to the pictures, to the videos that we took during the ultrasound, so we can look at that parallel to the operation. So we do not necessarily have to have the ultrasound probe in the patient during every operation. It's an option. There's an ultrasound device in the OR. That's absolutely true. But most of the time, the exam will be before the operation.
And another question: is there any practical way to find ureter? Where is the ureter in the bladder, in segmental plan, transferal plan, or other plans? How can we find this is the base of the bladder, dome of the bladder, and how can we find the bladder and ureter relationship?
Yeah. The way I do it is I put in the probe into the vagina until the trigone area, basically. So a little above the urethra, which is easily to find, I think, easy to find. And then when I learned it, somebody told me, or the person that taught me this, he said, well, you have to think of Bruce Lee. Bruce Lee, I will try to demonstrate. He will always go like this or like that. Obviously, you do not want to hit your patient, but what I'm saying is you're putting in the probe like this, and then you go a little bit like this, you go a little bit like that, and then you will find the right and the left ureter. And you have to play a little bit, obviously, and I think Katarina will probably be able to say something about that, because I think that's really a challenge to go behind the uterine vessels. I think that is not so easy, actually. I will say that I do not see the ureter after the uterine vessels every time. Yeah, I would say that.
Katarina, do you say something about this issue?
I also start from the trigone. I look for the meatus uretrale of this, and you can see it very well. The most important thing is to scan with a little bit full bladder, which is the new thing, because generally we scan with an empty bladder. Scan with a little bit full bladder, not too full, not too empty. And then from the meatus, you move a little bit, rotating the probe, and you have to follow very, very closely the ureter. When you find it in the intramural part, then you go in the retrovesical part, then you have the arteria uterina, and then very slowly, you go very small, and you can find it with small rotation. It's not too difficult. I said to my fellows every time, you never had to see when you have to take the femur length by fetal scanning, you have to rotate and to find the femur like this, because obviously you need to find a good plane where it is, and therefore ureter is not always in the same plane. So you have to look at this. The help can come from 3D, and probably will be a help, because 3D gives you the volume, and so give you the help to find also, especially if the uterus is dilated, where exactly it is. But finally, it's not too difficult.
Just quick question. Do you prefer, for both of you, do you prefer something special day, I mean during menstruation, before or after menstruation, or just any day during the menstrual cycle for the good result of the ultrasonography?
Well, if I can answer for, perhaps to that, we do not perform the ultrasound on most of the time on a special day. The patients just come to our department and would do the ultrasound then. So it will be at every stage of the menstrual cycle. I find that in most cases, this is absolutely adequate and enough. In some cases, it is better to perform the ultrasound and the exam again during the menstruation period. I think that is especially the case for endometriosis of the abdominal wall, for example, because if it's a huge lesion, you will find it anytime. But if it's a smaller lesion, it might be hidden from detection when it's outside of the menstruational period.
Katerina?
I prefer to see generally on the secretive phase, especially for the adenomyosis too. And I will always have, if I have a thicker endometrium, is better. Finally, we cannot choose every time. So we have to adapt, and we see deep endometriosis in every time of the cycle. The problem is, at first, pay attention to make a diagnosis of adenomyosis during hormonal therapy, because hormonal therapy gives you some, especially on the myometrium, some difficulties to see adenomyosis. So it's better to see outside the hormonal therapy. Unfortunately, we have a lot of patients on hormonal therapy, and you can see deep endometriosis and also very good, but for adenomyosis, it's not so good. And secondly, if we can, and we suspect deep endometriosis of the rectum, it will be better if the rectum is empty. But as well, we have to often to see patients during everything, because they come and they don't know to need a preparation. But if you can choose, it's better. Secretive phase, empty, rectum, little bit full bladder, and not on hormonal therapy.
That's good, thank you. Stefan, elastography, you mentioned about elastography. Do you use this one for the diagnosis of the endometriosis routine, or just sometimes? Just
sometimes, actually.
What is the reason?
Well, because I think that most of the time, well, it can be a nice addition, I would say that, but looking at deep infiltrating endometriosis, I think it's not absolutely necessary to add that. It's easy to use it because you can just push on the button on the ultrasound machine. It's not difficult to use the elastography. But I think that the 2D ultrasound is really a good enough tool to diagnose most patients with deep infiltrating endometriosis. If there is a doubt, well, I would add everything that I have, basically, using 3D ultrasound, basically using possibly also elastography. But I will not do that routinely with every patient and every setting or every area that I'm looking at. The only special exam that I will do using the elastography is the adenomyosis diagnosis. Not because I think it's absolutely necessary to add that, but I think that there is a special pattern that can be seen possibly, and I'm just looking at that from a scientific point of view. But yeah, it's not a routine procedure from my point of view.
Another question: you use the 3D ultrasonography, right?
Sometimes.
Yeah, just for the junctional zone or something else?
Well, the junctional zone might be one of the cases in which 3D is used. Yes. Katerina said, well, finding the ureter might be a 3D or point, if you will. And in any case in which I think it is not so easy to understand the 2D ultrasound, let me say that. If I have a good impression with a 2D ultrasound, because there is limit of time also, I will probably just go with a 2D ultrasound. But if I do not really understand what I'm looking at, or if I'm in doubt, the 3D might help.
In my practice, just my practice, I am using a lot of uterine abnormality in endometriosis patient. I mean, arcuate, subarcuate, subseptus, something like that.
Right.
Do you see this one in your patients?
Well, we see that also as well. Obviously, yeah, absolutely.
And the polypoid appearance and endometrium. And you see in your practice, if you see the not just polypoid endometrium, I mean the uterine cavity, do you do something or just looking?
Well, that depends. If I think that the ultrasound picture that I'm looking at is so good that I think that what I'm looking at is like a polyp or it's a myoma or something like that, and I'm sure of that, I will just go with the 2D. But if I want to have a better picture, or if I'm in doubt, then the 3D might also help, obviously. Yeah.
Katerina, for the polypoid appearance, do you do something?
Yes, at first I do the color Doppler. If it's very vascularized and I suspect some cancer, I do nothing. I send it to hysteroscopy for the biopsy. If it's not so vascularized, probably I will do a sonohysterography so that I can see the polyps, I can see how much it is, and so it is good to have directly an operative hysteroscopy, or I can do also not a blind biopsies that I can go to treatment. So I try to make a hysteroscopy, sonohysterography always if I can see better the cavity. And,
Thank you.
I want to say about 3D. And so, Sebastian, you mentioned very good that you measure the deep endometriosis in the rectum, and you measure it with a line. And I think this is not a good thing, because the bowel is often not a line. And this brings to you that you underestimate the bowel lesions. And this is why I often use 3D, because the bowel lesion is never on the same plane, and often it's curved. So otherwise, or I used to measure it in a curved line, or with a straight line, but acquiring the volume, so that I'm sure that the bowel, because you know that we have the entrance 4, and the entrance said 3 centimeters, 2 centimeters, and it makes a great difference if it's 3 centimeters or if it's 1 centimeter. And with this line, often you can underestimate.
Yeah, that's true for the measurement. You're right. You're absolutely right. I think that you still get the impression of the lesion if you're looking at the 2D in the moving picture, basically during the exam. If you're just looking at the shot, obviously you will not have the good assessment. But I think there's definitely a difference if you have a lesion which is straightforward, just in one plane or in 2 planes. It can be measured using the straight lines. Or if you have a lesion which is curved and in which you would do that and underestimate it, I think that definitely there's a difference. But I think the 2D helps you. The 2D is good also for diagnosing this curved aspect, if you will, of endometriosis. The measurement, you're right, will underestimate, but you will be able to say, well, this is a lesion which, well, it involves, like, let's say, 5 centimeters or so of the length of the frontal rectal wall, and not only the, well, if you just go straight line, 3 centimeters, that it's from point to point in one picture. So you're right. If you want to really have a good measurement, you can either do segments in the 2D and add that, or better, you're right, use the 3D for that. Yes, that's true.
Sebastian, another question. You are an oncologist, and they are asking, you suspect a deep endometriosis nodule.
Right.
Do you do to exclude the rectal cancer? Do you do endoscopy, rectal endoscopy, or biopsy for this patient? Sometimes maybe she has the rectal cancer instead of the deep endometrious nodule.
Well, if the patient has hematochezia, if the patient has a positive family history, if there is no other sign of endometriosis, if you will, if she doesn't really have an endometriosis anamnesis, I will at least send her additionally to a gastroenterologist for a rectal exam or rectal endosonography, rectoscopy, and possibly also obviously coloscopy. If the patient has typical symptoms, for endometriosis, and I have a lesion in the rectal wall, then I will basically discuss with the patient if she is symptomatic. A lot of times she will then go into the OR later on, and in the workup for the preparation of the operation, I will send her to my visceral surgeon who will be with me in the OR, and he or she will then perform rectoscopy and basically exclude this possible differential diagnosis. If I'm looking back some years, our surgeons, they always wanted to have a full coloscopy, and that is something that I think is not necessarily if you really have anamnesis. The rectoscopy, I think, is good, especially in preoperative workup, but the full coloscopy is most of the time, I think, not needed. It will sometimes we do it still if during the rectal exam there are signs of let's say polyps also additionally to the deep infiltrating endometriosis. If she has hematochezia and the rectal wall is completely normal, then obviously you will have to look at differential diagnoses.
And the last question of the webinar, for the appendix and the sigmoid and ileum and the bowel endometriosis, do you prefer sonography or the MR?
Well, for the appendix region, the sonography is okay. I think that's an area where you should also look. But if she has let's say she has bowel symptoms like constipation, she has right side pain, and you do not find anything in the ultrasound, I think then an MRI is a good idea. And during the MRI, you will probably then see the cecal or ileocolic or appendix endometriosis.
Dr. Schäfer, thank you so much. Katerina, thank you for your contribution. You are a master of this subject in the world. Thank you so much. Actually, our next webinar will be next month in July, 14th of July. The speaker will be Dr. Hans-Rudolf Tinneberg. I mean the founder chairman of the EEL. I mean the 15 years ago. He will speak about the complementary medicine of the treatment of endometriosis. We are waiting in that webinar, all of you. Thank you for tonight. You spent some time. Thank you so much. I appreciate it. Good evening to everybody. Thank you, Dr. Schäfer, again.
Well, thank you, and good evening to everybody as well from my side.
Bye-bye.
Bye-bye.